and welcome to Health Matters on Channels Television. I'm Yomi Otaigbe. Do you or someone close to you experience recurrent attacks of breathlessness or wheezing sound in your chest? If so, you need to pay extra attention to our discussion today on the program, which is centered around asthma, a respiratory non-communicable disease which is common among children. To shed more light on this condition, I have with me in the studio a consultant chest physician who is also the head of respiratory unit of the Obafemi Awolowo University Teaching Hospital, Ile-Ife in Osun State, Professor Gregory Erhabor. Good to have you on the show.
Thank you very much for having me.
Thank you for coming. Tell us more about asthma and how it affects the lungs.
Yes, asthma is from the original name of asthma. It means difficult to breathe, and it's a disease that causes narrowing of the airways and makes it difficult for those who have the condition to breathe properly. And so they exercise symptoms like cough, chest tightness, wheeze or whistling sound, and then sometimes they may have all kinds of allergies associated with it. So that is basically the problem. They have chest tightness, they have cough, they have wheeze, they are breathless, and they may have associated allergies.
Okay, so it's something that has to do with, as I said, the lungs and the airways.
Yes, mainly the airways, and that is the airways that causes the narrowing. But the initial problem of the asthma itself is what we call an inflammation. The airways are inflamed by a lot of cells, and the consequence of that inflammation is the narrowing of the airway. So inflammation is what causes the airway narrowing, and the airway narrowing is the expression of the inflammation in the patient.
Okay, so why will the airways be, inflamed?
Yes, there is a lot of hypotheses, but the almost certain thing we know is there's a combination of genetic and environmental factors. As we always say, we say the genes give us the gun, environmental factors trigger up the attack. And so when families have, people in their family have asthma or has allergies like rhinitis, that is they have running nose, or they have sore throat, or they have itchy eyes, runs in families, they have a predisposition to have asthma. But it doesn't necessarily mean that if your parents have it, you must have it.
Like you were trying to explain to us earlier what happens to the airwaves. As we can see on the screen, there seems to be that on the left side, for me, it's normal airways.
Yes, clear airways, yeah.
Okay, and then there's the narrowing.
Narrowing airways. And what we are trying to avoid, if you look at the one with clear airways, then in the middle one, you see the airways are narrowing, and the latter one, the airways are really narrowed properly. We don't want a situation in which the airways get so narrowed and it changes the whole geometry of the airways. And so we want a situation in which if your airways are narrowed, you have treatment regularly and frequently, and that prevents a structural damage to the airways. Okay,
now tell us more about the causes or the risk factors for this.
Yes.
We're talking about genetics.
Yes, the risk factors is genes, and we don't clearly know. There are several genes that have been implicated in asthma, and as we always say, it doesn't follow the Mendelian fashion. That is, it doesn't necessarily mean that if your father or your mother have it, then you will have it. It can skip a whole generation. So there must be a gene predisposition. And the markers of those genes are shown by allergies in your family or full-blown asthma. Then after that, you also have to have the environmental condition that favors the attack. And the environmental condition can be divided into different forms. One is the indoor environmental condition. We call things like house dust, things like fumes at home.
So there's the things that can trigger
asthma. So indoor environmental factors, like cockroaches, like house dust mite, like pungent odors. They will have outdoor environmental factors, which also have things like pollens, change in weather, exhaust pipe, changes in industrial pollution, and then we also have other allergens like drugs. There are several drugs which we know can trigger asthma. Then there are non-specific factors like emotions, like pregnancy, like menstrual period.
We see in that picture a woman laughing, you know, that could...
Yes, a laugh can do for some people.
Wow.
So most of these things are rather inciters. To some it may cause asthma, to others may not cause asthma. And that's why we always say, study your own asthma so as to know which factors that trigger your asthma. What may trigger A asthma may not trigger B asthma. So from your own experience, you can easily identify the factors that can trigger your asthma.
Now, some other conditions, I would guess, you know, can mimic asthma. You find some other people having breathing difficulty and they have not been diagnosed with asthma. Tell us about this other condition.
Well, there are several conditions that can mimic asthma right from childhood. There's a condition we call acute bronchiolitis that can mimic asthma. Some viral infections can also mimic asthma. When it now comes to the adult, things like congestive heart failure can mimic asthma. But one of the greatest mimic of asthma is a disease we call chronic obstructive airway disease. Now that disease is similar to asthma, but the difference about that disease and asthma is that it occurs in the older age group and is usually usually caused by smoking or indoor pollution. All other things are not really as close to asthma because there are very few conditions in the normal state that can give you wheezing, chest tightness, and cough. And so in many cases, if it wheezes and you wheeze at night, you are associated with allergies, you have a family predisposition, it is asthma until proved otherwise. Okay,
so how do we now know that this particular wheezing or breathlessness is as a result of asthma, the diagnosis?
Yes. Now, doctors always say that all that wheezes is not asthma. First of all, you must have the symptoms. Then secondly, you must also have the genetic predisposition. Then the symptoms, there are cardinal things about the symptoms. If the symptoms occur in the night, if the symptoms are precipitated by these exogenous factors we talk about, if the symptoms have response to what we call beta-2 agonists, we can say it's asthma. Then we now do other measurements, which we call physiological measurements. In that physiological measurements, we take a patient to an instrument we call a spirometer, and it blows in as fast as it can, and then through some other tests we'll do, we can pinpoint that this patient is asthma. But there's another simple way which we diagnose asthma. This happens in children. Sometimes we tell somebody to exercise for 6 minutes. If he has asthma, after the exercise he will wheeze, because almost every asthmatic will be induced by exercise. And so that is a very simple way of diagnosing asthma. So you use your symptoms, the frequency of the symptoms, allergies occurring in the night, and also the fact that the patient will do some spirometry and some exercise tests. There are more complicated tests which you can do, but I think basically almost 99% of asthmatic can be diagnosed with a simple physiological test and the symptoms of the patient.
Okay, so if we want to be sure that this is not any other thing, we need to look at all of this, and that means the patient must be taken to the hospital.
Yes. You see, I've had a situation in which a patient had been given antibiotics for over a month, you know, and because he was wheezing, he was coughing, and some people thought he had chest infection, and really he had wheeze, he had asthma. Now, if that patient had not been diagnosed, he would have died. And some will say that he died out of infection. So whenever a patient has wheeze, he has chest tightness, don't assume that patient must have physiological measurements. But I also want to say that asthmatics have a poor perception of the asthma. What we mean by that is that if their symptoms are serious, they may say it's nothing wrong with them. So that because of their poor perception, they don't have, if you don't do any objective measurement to measure their asthma, the patient may be dying and you say, I'm doing well. And that's why many asthmatics die, because they have their blunted perception of the state of their health. And so they need to see a doctor who will do the measurements that are necessary to diagnose asthma.
So if you have this wheezing, recurrent wheezing, and all of the symptoms that you've mentioned, don't just think it's something, okay, I can wake up out of this, or just get better. It's something you need to seek help for.
Yes, you need to seek help, because several people, you see, we always say that about 250,000 people worldwide will die every year because of asthma. And we feel they will die because they are underdiagnosed and because they are undertreated. And in fact, because they are not even diagnosed. So diagnosis is one of the big factor, because death for asthma is vastly preventable.
Okay, now I know that there are different levels. Some people have mild, and tell us about this, and perhaps maybe this could account for why some people would think, well, this is not asthma. I'm not having asthma. It's just a one-off thing,
Yeah, there are so many myths about asthma. Some people say, well, because I had asthma when I was young, but now I've gone over it. Well, doctors not completely agree that you can get over your asthma. Although some people talk there's a rule of third, that some people will get over the asthma, some of the asthma will stabilize, and some of the asthma will worsen. But we don't believe that they can get over the asthma, all that.
Okay, so sorry, let me just add this. The symptoms, like we have on the screen right now, so we have the types of asthma.
Okay.
You've talked about exercise-induced.
Yes.
So could it be this severity, could it be as a result of the type of asthma that person is having?
Well, the severity of asthma varies. You see, when you have an adult asthma, you are likely going to be more severe than if you have a childhood asthma. If you have asthma that is usually triggered up by allergens, you are going to be less severe than asthma that you cannot get an identifiable allergens. But if for any reason you are waking up more times in the night because of your asthma, more nights in a week because of the asthma, and your asthma is not responding to your normal inhalers, and the different method of inhalers, and then you also need to take additional drugs to get your asthma controlled, or you have recently been admitted because of asthma, then you are at risk of having severe asthma. And that patient will need to be managed properly, because that could also lead to a progressive decline in this condition.
Okay, so quickly, let's talk about the aspect that, okay, if the attack starts now, how long will it take for the person to say, okay, mine is mild, my asthma is severe?
Yes, there are some things doctors always look at if you say your asthma is severe. One, if your asthma is severe, you have a lot of what I call, you find it difficult to breathe. You also find it difficult to complete a sentence. You see, you're not speaking monosyllables. Then your breathing would increase more than normal. Your heart rate would increase more than normal. And also, you find out that when you do the normal spirometry test you normally do, it will be far, far reduced more than normal. Then you are not responding to conventional drugs, the inhalers that you normally respond to. Then it shows that your asthma is getting severe. So your breathing, your heart rate, how you feel in terms of anxiety and not completing sentences, then your asthma is getting more severe.
Severe. Okay, we'll just go on a quick break now, and well, Health Matters returns. We'll be talking more about how to manage this and, of course, prevent recurrent attacks of asthma. Stay with us on the program. Back. It's all about understanding asthma, and if you have any questions, comments, you can join us in this discussion. The number to call will be on your screen, and you can also send your tweet to at CTV_YomiO or at Yomi_Otaigbe. We can take up your questions and comments. Okay, now let's talk about the management of asthma. This is very important, as you've said.
Well, there are many levels of management of asthma. The first thing we do in managing asthma is to determine how severe it is. Now, broadly speaking, for the layman, asthma can be divided into two broad groups, the intermittent and the persistent. The intermittent, simply put, are those that just come on and up, and then the persistent are those that stay for some time. And within the persistent, it could either be mild, moderate, severe, or very severe. Now, how do we manage asthma? First of all, one, education. Asthmatics must be educated about the cause of disease, about their triggers, and also their caregivers must know about it. Two, avoidance strategy. When you know your triggers, you can find strategic ways of avoiding them. The doctors can run you through those situations and tell you how to avoid them. Three, self-management. We always say that asthmatics should know how to control the asthma, and we'll teach them various things to use in order to know how to control their asthma even when the situation is getting worse. Then 4, there must be a synergy between the doctor and the patient. 2 of them will be co-managers of this condition. It cannot just be a unilateral role by the doctor.
And if you say the doctor now, you're talking just about the general practitioner?
Yes, a general practitioner can manage asthma, but there's a level to which he needs to refer, especially when it's a difficult asthma or if the asthma is not responding to normal therapy. When it comes to drug, there are broadly 2 kinds of drug. The drugs we call the relievers and the controllers. The controllers are those that prevent attack, and they're usually steroid-like drugs. And then the relievers are drugs that tend to take care of the attack when it happens. We don't encourage people to use the relievers very often if they don't have attack, because that could worsen the asthma. And as doctors say, could increase their hyper-responsiveness and make the asthma worse.
Okay, try and explain that. If a person with asthma or an asthmatic doesn't have the attack, then he shouldn't be using the reliever.
The relievers, but he should use the controllers. The controllers are the drugs that he takes often and on to reduce the inflammation and thereby deals with the mechanism that caused the attack. Also, we also say that the drug should be taken by inhalational route.
Okay, hold on. I think we have a caller. Hello.
Also, we also say that the drug should be taken by inhalational route.
Oh. Hello.
Hello.
Thank you for joining us. Please go ahead with your question or comment, and please turn down the volume of your TV set.
Hello. Hello.
We can hear you.
Hello.
Okay, I think he needs to sort out something there.
Yes. So we said that the drug should be taken in form of the inhalational route. That is, it should be by inhalers. Why? Because smaller doses produce a greater effect. 2, it goes directly to the airways. And 3, you do not have all the side effects. We say avoid oral drugs by all means, because they go to the GIT and they don't go directly to the oral route, and they have a lot of side effects.
What are the side effects?
Yeah, the side effects that the patient could have shaking of the hands, it could have the heartbeat could be faster, and sometimes can also have affect some of the the elements in the body, like the potassium. But the most big effect it does is that it causes tremors and it can lead to palpitation. And also, it will not even get the right dose to the airways. Then the other way we manage is that we should also advise them to use what they call a peak flow meter. A peak flow meter is a simple instrument that every asthmatic should have. I've always told people that just as this sphygmomanometer is useful for everyone that has hypertension to measure his asthma, measure his blood pressure. So everyone that has asthma needs a peak flow meter to measure his his asthma. Then they must also know when the asthma is getting worse. That is, as I mentioned before, they're having more night attacks, they're waking up more nights in the week, they are getting more wheezy, their drugs are not getting functional, and they are exposed to newer environment that cause asthma. And let me give you a simple example. There's a patient we admitted some time ago, and this patient was not doing well, in spite of all the measures we are taking, all the drugs we are giving. At one point, the patient told me that I feel this hospital environment is causing this difficult problem, and he wants to be admitted in a nearby hotel, and he comes to see us. He kept on agitating. Then I gave him the opportunity to go and come back and see us the next day. Over 2 or 3 days, he was coming to see us, and he was getting well. We now late recognized that the hospital was being repented, and that patient was reacting to the pains in the hospital. These are what we call occupational sensitizers.
Okay.
So
let's see if the caller is back now. Hello.
Hello.
Thank you for joining us. Please go ahead with your question or comment.
Hello.
Hello, we can hear you. Please go ahead.
Hello. Hello, good afternoon.
Mohammed, good afternoon. Go ahead, please.
Yeah, my name is Mohammed.
I want to find out this. I want to ask the doctor if my son is asthmatic. I can't hear you well.
Go ahead, Mohammed. Go ahead.
I can't hear you.
Go ahead. You. Okay, I think it's gone. Mohammed is gone.
So I found out that there are other things that I will not know. So we find out the asthma is not getting controlled. Look outside the environment. That there may be other things that are not helping the drugs to get controlled. Or there may be a heightened emotion. The patient may be going through a stressful situation in life. But you see, there are other people who believe that there are other things that can help take care of asthma apart from the drugs. They believe that they can use some non-drug things, but I think most of them has not been proved. Some will say they can use acupuncture, some will say they can use yoga, some say they can use herbs. I would like to say that if a thing has not been universally authenticated or universally accepted, you should try to minimize its use, and if possible, discuss the health practitioner who will look at the literature and see whether these things are viable. But having said that, a positive outlook to your disease is important. If you have asthma, the fact that you must have optimism. Don't begin to have a sick person effect, to believe that, well, I'm so bad, I'm not doing well. Just keep being positive about your health. Keep believing that you can be better. Keep to your medications, and you can do well.
Now, this week, the national guidelines for the management of asthma was unveiled. Tell us about this, because I was thinking we already have a way where we manage asthma. Why this guideline again?
Yeah, you see, guidelines are what is prescribed universally for the management of diseases. But apart from the universal prescript of guidelines, you have to localize or situate guidelines to the local environment, because diseases have different ways of manifesting. We always say that asthma has different phenotypes, different genotypes, and different endotypes. So the types of asthma we find in the African type may not be the same we find in the Europeans. So we need to situate guidelines within our own environmental conditions.
So give us briefly what this guideline.
So the Nigerian Thoracic Society for about 2 years now have been looking at the worldwide literature and studied all the various work that have been done in asthma in this country. And we have produced a document for the management of asthma in Nigeria. And this document covers asthma in pregnancy, covers occupational asthma, covers asthma in children, covers difficult asthma, covers severe asthma, and covers chronic asthma. So with this guideline, doctors now know what they can use to manage asthma. But I also want to say that guidelines are not necessarily built cast in stone. It does not disturb the doctor from using his initiative. These guidelines will be widely available in all the hospitals, all the physicians, all the medical schools, so that they can have it.
Okay, and finally, is asthma curable?
Yes, you see, doctors don't like to use the word cure. We like to say that asthma can be managed, and you can live well and a good quality of life even though you have asthma.
Thank you so much for coming on today on the show.
Thank you very much.
And thank you all for watching at home. It's been talks around understanding asthma, and if you or someone around you is having all of these issues, I think this is the best time to seek medical help. Thank you for watching once more. I'm Yomi Otaibi.